So it's important to realize what we can do with the ferritin level. If the ferritin level is decreased, we have proof that there is not enough iron in the body. If the ferritin is increased, this suggests iron overload. However, you have to be sure that there is no inflammation going on, because if there's inflammation going on, this ferritin would need to be seen in another setting. And therefore, it's sometimes a little iffy to decide whether a certain amount of ferritin represents a sufficient iron load. But in general, for most of the assays used, and I state that specifically for most, not all of the assays used, you can assume that if you're above 100 to 200 mg per liter, you can assume that you're not iron deficient. Okay? Now, what happens if you bleed right away and you lose, I say, a liter of your blood? And remember, the biggest iron store are your red cells. What happens to the ferritin? At that point in time, the body did not have time to adjust. If you measure ferritin then, you still might have the impression that there's enough ferritin around, but yet would have lost a big part of it. So with very short-handed changes of iron stores, ferritin might be a little bit behind. But in general, you will see the reaction within 2 to 3 days. However, the other thing to remember is that ferritin is essentially present in every single cell in your body, because every cell has an enzymatic system that needs iron. And this means that if cells in your body break up, like for example happens with liver disease, then you can have a lot of ferritin coming to the circulation, independent of whether there is a lot of iron around that. So you will measure a lot of ferritin in the circulation because of the breakup of the cells, but that does not mean at that point in time that you have increased iron load. So besides the acute phase, you also have to be sure that there's nothing else going on, such, for example, as acute liver failure. I think we'll go over that real quick. The transference saturation, I think, is important to be taken from a fasting patient. Why is that? As you've seen before, if you have a lot of iron in your gut, you will resorb part of that iron, and if your iron comes to the circulation, it will be put onto the transference, and that is how you calculate the transference saturation. Now, if you put a lot of iron in your gut, you will have a lot of transference saturation, right? So you have to have a basis where you judge the transference saturation, and that is why patients should be fasting when this is measured. So we said that acute phase reaction need to be excluded, which is done by a C-reactive protein that allows you to determine whether there's an additional acute phase going on. And we talked already about the soluble transferrin receptor. Now this is another important picture which tells you that if you decrease your iron stores, you will not see a reaction with transferrin saturation or the hemoglobin unless your iron stores are empty. If your iron stores are empty, then you start losing your structural iron. However, as the ferritin is a reflection of the total iron store, you will see a decrease in the ferritin concentration as soon as the iron store goes down. I think because we're a little over time already, I just switch to a very brief thought on whether you can really state by ferritin, if you have excluded an acute phase reaction, whether somebody is iron deficient or not, and where that cutoff lies. I just want to mention real quick that there are clinical studies suggesting that at a cutoff of 30 micrograms per liter, you are able to separate between normal and deficient iron stores. And the story behind that is that one did that in young athletes, but I think this will go beyond the scope of this talk. However, it clearly shows that 30 micrograms per liter are the cutoff that we can use at the time being to differentiate iron deficient patients, somatically iron deficient patients from those who are not iron deficient. However, if you look at depression, that there is a correlation between depression and iron deficiency starting already at around 40 to 45 micrograms per liter or nanograms per milliliter. So a general cutoff, I think, would be 40 to 50, then you should be on the safe side. And we have seen in prospective studies from this area, from the Zurich hospital, that patients that have an increased fatigue, that they would benefit, that they profit from iron infusion if their ferritin level is clearly decreased. And one last suggestion, it's not always necessary to give IV iron. You can do that by oral iron too, as shown here from North Africa, where children were fed with an oral iron preparation. And you could see that within 10 months, they have clearly, with the oral iron preparation, first of all, increased their ferritin level to above 30, and interestingly enough, by increasing their ferritin level from 15 to above 30, they became non-anemic. So they increased their hemoglobin level from 113 to 128. Now, one other suggestion to think about, specifically if you give patients IV iron, specifically young women, think about the decrease in the ferritin level. If you see a decrease like here within 3 months from a ferritin level that comes down by 42 or 32%, there's no other way for them but losing their iron. And in young women, this is usually in the bleeding from their menstruation. And it's important to really ask those patients how large their menstrual blood loss is, because most of these women grew up with that. For them, it's normal. So it's your task to quantify how much they really lose. And if you work those patients up, you can find up to 80% of patients that have either a von Willebrand's or platelet dysfunction, which leads to this huge blood loss. And this can easily be controlled in the perimenstrual setting with a fibrinolytic drug. So my conclusions are that we, again, should always put diagnosis in front of therapy. We have to be realistic about the ferritin reference intervals. They can be population dependent and can be depending on the pathology. The best evidence that we have, if at all, is that the cutoff for the ferritin is with 30 micrograms per liter. However, if you go up to 40 or 45, I think you're on the very safe side. There is indeed an association between fatigue and reduced iron levels, such as represented by low ferritin, and there are indications that depression is also associated or can be associated. However, oral iron can be part of the replacement therapy, and in fact, it should be suggested that only oral iron is non-functioning in these patients or increasing the ferritin level, only then IV iron should be used. And with that, I thank you for your attention.
Thank you very much for your presentation. Great questions, please. For the women, after their menopause, can they compensate this iron level?
They do. They do. So during menstruation years, women are usually iron deficient when compared to men. As soon as they come to menopause, they catch up. Okay? And as soon as they come to menopause, they also lose their survival advantage, which is interesting.
What is, did I get this right? The biggest source for the therapy, not the therapy, for the iron in human body is the erythrocyte, right? The red cells.
Stored, yeah.
Okay. So what if the red cells, they have life like
120 days
yes.
normally.
What if it's lower than this? Can this also cause deficiency?
Usually, good question. But if you think back that if you're non-anemic, that's a question, that's an important question. If you're non-anemic and the lifespan goes down, then this requests that your production rate goes up. And your production rate only can go up if you have adequate iron stores. Otherwise, your production rate won't go up. So the question then is, where is that? Where is that situated? Is that in an anemic setting? In an anemic setting, yes, it can be a problem. If it's in a non-anemic setting, then, like for example, in sportsmen, in athletes, then you have to assume that they have enough iron on board, because otherwise they would not be able to build up the amount of erythrocytes with decreased survival time.
So it makes like when it's in an anemic phase, then it's like that. Then it makes it stronger. The deficiency, or
You could argue that.
Actually, you have mentioned that one picture with the half glass, full half glass empty. I mean, you have said that either for iron deficiency, your iron intake is not enough, or you're losing too much iron. What I know from some observational studies is that, especially in southern countries, like Turkey is one of them, iron deficiency is quite high. So is there a specific reason you can, is it because of the nutrition that you take? Can it be one of the reasons, or are there what other reasons for that iron deficiency in southern countries versus European countries?
So you're absolutely right. So this study, for example, was from North Africa in not adequately fed children. Okay, so this just represents the suggestion that if you increase the iron intake in an adequate way, your system can regulate. However, in the European countries, or those so-called industrialized countries, we have enough meat intake that we should have enough iron. So the question then is, if the iron deficiency, in quote-unquote, is present there, how do you define deficiency? That's the next question. And that's why I suggested that from all the studies that we have, the cutoff of 30, but if you want to be more on the safe side, of 40 to 50 mics per liter should be okay. That's what all the bone marrow studies tell us. But I agree with you, it depends really on the setting, and that's why I always also said you should be aware that there might be population differences when you come to judging the ferritin levels.
During the lecture, you had told that ferritin triple positive is converted to ferritin double positive by an enzyme. I think it was reductase.
Right.
This enzyme, is it the levels of this enzyme the same for everyone, or does it change?
That's interesting. Probably not. But the problem that we have is that we, at the time being, we cannot be sure that if the reductase is not working, it might be a consequence of a GI disease. So we do have, for example, just in Switzerland, a lot of focus mass for or a GI disease that reduces the activity of this enzyme and thereby reduces the resorption of the iron. Okay. Now, are there polymorphisms of this enzyme? Very likely. But how do you get these differentiated? That's a hard thing to do in an epidemiological study.
Jetzt würde ich Dr. Hakan Sarıkaya, hier sind Damen.
Değerli konuklar, liebe Kolleginnen und Kollegen, sehr verehrte Gäste, es ist mir eine große Freude, Ihnen in den nächsten 15 Minuten zur Hirnschlagprävention vortragen zu dürfen. Ich komme zu einer Person, ich bin als Oberarzt auf dem Neurologie-Spital tätig, habe damit eine Praxis in Basel und bin als Privatpatient an Studenten unterrichten in Zürich. Kurz zur Übersicht, da die Zeit wirklich knapp ist und wir ein heterogenes Publikum sind, habe ich mir erlaubt, kurz das aufzubauen. Ich werde Ihnen kurz allgemeine Informationen zum Schlaganfall geben und dann über medizinische Maßnahmen und Lebensstillmodifikation berichten, die zur Prävention beitragen. Für diejenigen Kollegen, die detaillierte Informationen möchten, verweise ich auf die 3 Teilartikel, die wir zusammen mit der Schweizerischen Hirnschlaggesellschaft kürzlich in der Schweiz offiziell publiziert haben. Gut, also in der Schweiz erleiden ca. 60.000 Patienten pro Jahr einen Hirnschlag. Weltweit sind es 15 Millionen Patienten. Man kann sich fragen, ist das viel oder ist das wenig? Es gibt aber andere Zahlen, die das veranschaulichen. Man weiß, dass weltweit alle 2 Sekunden ein Patient einen Hirnschlag erleidet. Alle 6 Sekunden stirbt ein Patient an einem Hirnschlag oder erfährt eine bleibende Verwunderung. Und das Schlaganfallrisiko ist 1:6. Das heißt, jede 6. Person hier hat das Risiko oder wird statistisch gesehen einmal im Leben einen Hirnschlag. Hirnschlag ist die häufigste Ursache für bleibende Behinderung im Erwachsenenalter, ist zurzeit sogar schon die zweithäufigste Todesursache weltweit und die WHO spricht schon von der Epidemie des 21. Jahrhunderts. Hirnschlag ist auch eine teure Erkrankung, Sie sehen es hier an den Zahlen, verursacht durch teure Intensivbehandlung, Langzeitpflege und natürlich auch Arbeitsausfall von gehirnten Patienten. Jetzt muss ich ein bisschen improvisieren. Zu Hirnschlagmechanismus, was sind die häufigsten Ursachen? Im Gegensatz zu Myokardinfarkt ist der Hirnschlag eher eine heterogene Gruppe. Man unterscheidet eigentlich hier sehen Sie jetzt einen Einblick in das Gefäß, in die Halsarterie. Und Sie sehen hier, dass es zu einer Lipidablagerung kommt. Es gibt hier einen Riss in der Plaque. Die roten Blutzellen, die akkumulieren hier und werden immer größer, die kleben sozusagen hier. Und das wird dann mit der Zeit immer größer und größer. Und es löst sich ein Gerinnsel ab und geht dann in die Hirnarterie und blockiert sozusagen ein Gefäß. Und das Gefäß, das nicht mehr verflutet ist, das stirbt sozusagen ab. Gut. Da waren wir. Die Frage ist, wenn das passiert, kann man gerade etwas dagegen machen? Kann man es behandeln? Vor 15 Jahren war die Antwort nein. Heutzutage haben wir 2 effiziente Therapien. Man kann entweder ein Medikament applizieren über die Vene, eine sogenannte Thrombolyse innerhalb von 4,5 Stunden. Das bewirkt, dass das Gerinnsel wieder aufgelöst wird. Bei großen Hirnschlagen kann man in gewissen Zentren auch interventionell das Gefäß wieder auflösen. Man sagt aber etwa, dass man ca. 4,5 Stunden Zeit hat für diese Behandlung. Deshalb ist es ganz entscheidend, wenn wir von Prävention reden, dass man dann auch die Leute aufklären, dass sie die Zeichen erkennen müssen und dass wir rechtzeitig das Spital aufsuchen müssen. Wir sagen, time is brain, not time is money. Hier sehen Sie den Grund. Man hat nämlich ausgerechnet, wie viele Zellen das bei einem Hirnschlag zugrunde geht. Und Sie sehen, Pro Sekunde sind das 32.000 Neuronen. Über Stunden, nach einer Stunde, wenn sie nichts machen, sterben etwa 120 Millionen Nervenzellen ab. Und bei einem Hirnschlag, wenn sie gar nichts machen, sind es etwa 1,2 Milliarden Hirnzellen, die absterben. Wenn Sie die Nervenbasen, sozusagen diese aneinanderreihen und danach ausrechnen, wie lang das ist, sehen Sie, dass es nach einer Stunde sind es etwa 714 Kilometer, diese Nervenbasen, die sich aneinanderreihen können. Das ist immens. Und wenn Sie das schauen, wie alt dieses Gehirn dann wird, sozusagen, also ausgerechnet an diesem Zelluntergang, sind es bei einem Hirnschlag ca. 36 Jahre, wo Sie alt sind. Wenn die Komprehension reden, ist eigentlich die Aufklärung ganz entscheidend. Es ist ein ganz eindrücklich, wie viel Nachholbedarf wir noch haben. Stellen Sie sich vor, wir leben in der Schweiz, das sicherlich die beste Gesundheitsversorgung weltweit hat. Und es ist aber leider immer noch so, dass nur 10% von allen Hirnschlagpatienten von diesen Therapien profitieren. Der Großteil einfach die Symptome nicht kennt, hat dann eine Armlähmung und geht dann mit dem ins Bett und reagiert natürlich nicht. Hierzu haben wir eigentlich eine Karte erstellt, die ist handgroß und mit dem Ziel, dass die Patienten aufzuklären. Auf der Vorderseite sehen Sie ziemlich stark angeht und das sind die wichtigsten Zeichen, die Sie kennen müssen bei einem Hirnschlag. Die häufigsten Zeichen sind entweder eine Gesichtslähmung oder eine Halbseitenlähmung entweder im Magen oder im Bein. Plötzlich eine Sprachstörung, die Leute können plötzlich kein Wort mehr produzieren, also verstehen die Sprache nicht mehr, oder eine Sehstörung. Wenn Sie eines dieser häufigen Symptome haben, dann müssen Sie sofort 154 alarmieren, weil dann zählt eigentlich viel nicht. Gut. Kommen wir nun zu der Frage, was Sie eigentlich alles machen können, um den Hirnschlag zu verhindern. Und meistens ist die arterielle Hypertonie der wichtigste behandelbare Risikofaktor.